Good afternoon, and thank you for joining us. We're delighted today to be joined by Dr. Pinki Munot, a consultant paediatric neurologist at Great Ormond Street, who's sharing her presentation today on diagnosis and management of juvenile myasthenia gravis in children. Thank you, Dr. Munot. Over to you.
Thank you, Sarah. It's a delight to share this presentation and experience. As you mentioned, I'm a consultant at Great Ormond Street Hospital, and for the past 12 years, I've been looking after children and young people with juvenile myasthenia, both in the clinical setting, but also in the research setting where we've been doing clinical trials. And it's been a great journey and has taught me a lot over the years. I will try and share some of the highlights here. So this is the outline of what I'm going to talk about. I'm sure the audience doesn't need to be told what is myasthenia gravis. You all know, as you know, the fact that you're watching this and listening to this, I assume you know someone or are yourself affected. I will be talking about the different subtypes and the clinical assessments I undertake when I see the children and the young people. I will also talk about the diagnostic aspects and some of the tests that you may undergo. After that, we will be talking about the treatments and how it has evolved in the last decade. Um, at the end of the presentation, I will talk about some of the challenges and the efforts that we are making as a team, nationally and internationally, to try and improve the care. And what does the future look like? So let's start with myasthenia gravis, what it is. We all know that it's a condition which affects our muscles. It's rare in children, but about 10% of myasthenia gravis starts in the first 10 years of life. And fortunately for the children, about half of them remain ocular, which is great. But in the others, it can progress to generalize. If it's going to generalize, it does show in the first couple of years. So in my cohort, I have about half and half distribution of ocular myasthenia compared to generalized myasthenia. Sometimes I have also seen in a couple of children, it's only limited to bulbar presentation, and that can be quite tricky in terms of presentation and management. Bulbar meaning, the muscles around the swallowing part and how we speak and swallow, that can be affected. The first manifestation that, as you all know, you notice with this condition is tiredness and what we call fatigue, which is in the muscles. So as you do more, you get more and more fatigued and tired. This may affect any part of your body, but predominantly the eyes, the swallowing muscles, the breathing muscles, the limb muscles, any of them can be affected, but the variability is there into which muscles are affected more. Um, as you all know, because of the crisis risk, this can be life threatening. But the good news is that there are many, many different treatment options. So, this is the little picture that I sometimes show when I'm teaching about myasthenia gravis. And this is the location in our body where this problem happens. This is the nerve muscle junction. We can see that there's release of this green circular acetylcholine, which has been binding to these receptors here. And when this process goes wrong, we tend to get symptoms of myasthenia. The process that goes wrong here is that everybody who has autoimmune myasthenia gravis develops these antibodies called anti-acetylcholine receptor antibodies. These Y-shaped antibodies that you see here come and bind to the receptors, and therefore this acetylcholine, which should be binding here, is not able to bind. As a result, you get progressive problem with the activation of the muscle and tiredness. Sometimes you also see musk antibodies, but these are relatively less common compared to the acetylcholine receptor, which is more than 80% of the antibody subtype. And when I look after children based on their age, we can almost classify them into three different groups. I've never really seen Lambert Eaton, so I try not to talk about it because it's not my own personal experience. But in children, I see them if they are newborns, it's quite often transmitted from the mother because the mother has antibody mediated myasthenia, and those antibodies get through the placental border and come into the baby. And when the baby comes out, those antibodies are still present in circulation. It can take several months for those antibodies to be removed by the body, and therefore during those few months you might see symptoms of myasthenia. In others, when these antibodies are not there from birth. They can develop them over a lifetime. It can be any time from infancy to adolescent age. I have seen pre-puberty, post-puberty myasthenia gravis, and these are the different antibodies. I have not seen LRP4 in practice, but I have seen a lot of acetylcholine receptor and MuSK antibodies related myasthenia. And a quick word about what we called fetal antibodies. So when there are women who have antibodies because of myasthenia gravis and they are circulating in their system, and if those antibodies are to the fetal subunit, the babies and the fetus can develop a condition called as Faris, where there are difficulties with tightness in the joints and weakness. So we often recommend and support good control of myasthenia during pregnancy to minimize these problems to the fetus and the baby. So let's dive into symptoms and signs. How do I diagnose them when people refer them to me? When my colleagues from the community, the GPs and the pediatricians, they send the children and young people to me. Most of the time, it's because of weakness. They have noticed that either their eyes feel heavy and they droop as the day goes by. They start to develop double vision because the muscles which move our eyeballs on either side are not coordinating with each other, and there's a squint. If it's not limited to the eyes and it has generalized, they will report difficulties with, climbing stairs or walking longer distances, performing PE in school or dancing, whatever activity they take part in. Sometimes, in some forms of myasthenia, they can also come in with reports of weakness of the neck muscles, and therefore the head drops forward or backwards. Occasionally, I've seen a child presents with difficulties with talking because the voice is weak. I remember a young lady used to play flute and she could no longer play flute. Uh, of course, that can be a risk with swallowing because of the choking risk and aspiration. Um, when the breathing muscles are affected, they can come in crisis. And sometimes in the acute wards, we see this type of presentation when they've come for the first time during an infection with a crisis, either to our intensive care unit or to the wards. And these are the different manifestations that they can present. This is a young child, as you can see, because of the heaviness in the eyes, there is drooping, and you can see that the chin is lifted to try and compensate for the lift. Also, there's often fatigue, so as the child looks up more and more, the eyelids come down and down. There's also restriction of the eye movements, double vision, and this often, for me, most of the referrals for this come from my ophthalmology colleagues in London or in our own hospital. And once I receive these referrals, they usually request me to try and optimize the treatment because in young children, they are really dependent for the development of the eye and the visual pathway on the stimulus from the vision. So if the drooping eyelid closes the, stops that pathway, there is a risk of visual loss, and we therefore work very closely with the eye specialist to monitor this vision. Occasionally, the ocular myasthenias can be seronegative, and I sometimes repeat them, 6 months to a year apart to see if they have converted. But I do have some children who don't show up antibodies, and they are more challenging because you're always worried at the back of your mind, is this something else? Could there be another condition here, or is it genuinely ocular myasthenia? In terms of axial muscles, we look at crisis presentation, as I mentioned earlier. Sometimes I have seen in this particular child, you could see that the breathing, what we measure is forced vital capacity, and the breathing muscles are weak because they're only working at 50% or 60% of the normal function. So this can be a good clue that the respiratory muscles are also weak, and we have to be vigilant about this possibility. So in my clinic, when children and young people come, if they can, I routinely get them to do this respiratory muscle assessment. Moving on to the different type of MG, which is MuSK MG. This is a special type in the sense that the antibody is not against the receptor, but against the MuSK antigen. And these patients tend to have more involvement of the swallowing and the neck muscles and the breathing muscles, less so in the limbs. So I certainly remember two um, young girls where the problem was mainly in the swallow and the trunk weakness, whereas if you ask them about walking and tiredness, that wasn't as much of a problem. The good news about this is that this one is very, very nicely amenable to treatment with rituximab. They respond beautifully, and both my young ladies are in remission with this medication. and completely asymptomatic. So I think if there is MuSK MG, this works very well. And in case there is crisis, we use plasma exchange because that tends to be more effective than IVIG. And we don't usually do thymectomy or a surgery to remove this thymus because that doesn't work in this type of MG. Looking at the swallowing difficulties and the bulbar muscle, as I mentioned, this can present in many ways like weak voice, drooling, difficulties in closing the mouth while playing a musical instrument, choking and aspiration. And these can be equally treated with pyridostigmine and immunosuppression, steroids, etc. So when I suspect this because of the tiredness and the fatigue, and I see that, okay, this is quite likely to be myasthenia because of the tiredness, what test would I recommend? What test will you go through? So first of all, I think the initial assessment is really important. The history in how the symptoms started, how they are, the children are reporting that they're getting tired during school examination. They're changing from what they were before. So I sometimes ask, what were you like in year one or year three? And how are you now in year five? Then I follow that up with an examination during the clinic. Once I have finished those two and I'm certain that this is quite likely, I will arrange a blood test firstly to check for the antibodies. And I may check for this test that we are doing here, where we are doing a stimulus to the electrical stimulus to the nerve muscle junction here to see what response we are getting, and are we really seeing the tiredness that we are seeing in clinic. Um, and if this antibody is positive, we also arrange for a scan of the thymus to make sure there's no thymoma, which is a tumor in the thymus. This is quite rare in children, but it has been reported in the literature. I personally haven't seen thymomas, but it's a possibility as well. So with a combination of these blood tests, scanning, and electrical tests, we can be sometimes um, fairly confident that this is juvenile autoimmune myasthenia gravis. And I say fairly because occasionally we do get seronegative patients, and I think those are the ones as I said, I have to watch out for, and they need a lot more investigations and follow up to make sure there is not another cause. So, moving on to treatment, what are the different options? I mean, it's quite similar to adults, but in a way, it's different because children are still growing, they are developing their immune system, they're also, have the growth factors to consider. In addition to that, we consider the vision development, which is still ongoing in the first decade. So, my first question is, what is my goal and what would I like for the child? And I think the goal I work towards with the families is that we shouldn't really have any manifestations, so minimum manifestations or no manifestations. And particularly for the ocular myasthenia, I would like to maintain good vision because I do not want risk of vision loss or what we call amblyopia. And the factors that I consider is the age of the child, how young, is it a male or a female, what is the level of impairment, can they function, can they go to school, can they eat, can they breathe, are they in ICU, and all these factors help me to decide what is the severity of the myasthenia and what are my choices in terms of treatment. So this kind of summarizes the guidelines or the process that we go through. So generic advice is about pacing because it's a condition that tires you. We recommend that children go slow, and don't have three after school clubs on the same day or have swimming in the morning and football in the afternoon and a whole school day. So pacing is really important to distribute the activities. And then our first medication often we use is pyridostigmine. The maximum we would use is 7 milligrams per kg, but often we start with a smaller dose of 4 milligram per kg per day in 3 to 4 divided doses. And we explain to the parents and the children what we expect in terms of side effects. Um, we encourage them to take the medicine just before meal times, half an hour before, so that they're strong if the swallow is weak. Also, try and time that according to the physical activity. So, we carefully consider what time that medicine should be taken. Like, for example, wake up in the morning, take it as soon as possible, and then maybe at lunchtime once they get back from school. And that's the routine. If the symptoms are manageable with pyridostigmine, for example, the eye symptoms sometimes can be managed. But in majority of the children, I've had to move on to the second line, which is a steroid medication, which is immunosuppression. Now, this works on the root cause because pyridostigmine really is a symptomatic treatment of the weakness. only for 4 hours or 3 to 4 hours, it will lift the eyelids or give you a bit of boost, but it doesn't do anything to the antibodies or cure the myasthenia. For that process, we need to work at dampening the immune system, because in these children and young people, the immune system is overactive. The medications that we use for that is called as prednisolone, and I tend to use it only alternate days. In the UK, we tend to use a maximum of 1.5 mg per kg alternate days, and we usually start on a low dose, and gradually increase and build up. Um, Sometimes, if the patient is in hospital and in intensive care unit and is very severely affected, we might use a bit intravenous methyl, pulsed methyl prednisolone. So that's an injectable form that goes into the blood, into the cannula. But majority of the times, if the child is well, I would start with oral steroid medication, which is taken by mouth. If the child is in crisis, then I may use medications like immunoglobulin, which is again a drip given in the vein, or a plasma exchange where we use a catheter and exchange the blood and filter the antibodies out. These two treatments tend to work quickly, and therefore we tend to reserve them for patients who are really severely affected and need to be, immediately need to be made better because of the risk um, to life. Also, we use this prior to surgery or surgical interventions like thymectomy, because clearly we are going to give the person an anesthetic, and that can compromise the surgical intervention. Therefore, it's good to have good, strong muscles before they are going in for surgery. So, those are the two situations where I tend to use IVIG and Plex. And sometimes, when the myasthenia does not respond to the intravenous, to the other medications, I put them on regular IVIG, as no other options are working. Other than these medications, I also use steroid sparing drugs. Mostly, I've tried to use azathioprine and MMF. I prefer not to use cyclosporin, but most of the time, this is a personal choice for the neurologist and what they are used to looking after and monitor. And my personal preference and experience is with MMF and AZT, so that's my preferred choice. I will then refer the children, if they have acetylcholine receptor antibodies for generalized myasthenia gravis, to remove the thymus. Um, if they are over the age of 5, 6, and the immune development has happened. Um, my cardiothoracic colleagues would do this under a laparoscopic procedure, with a minimum invasion or minimally invasive procedure. And often the hospital stay is no longer than a week if there's no complications. Majority of the time, it's a couple of days in the intensive care and then on the ward. They are usually well tolerated if the child is well prepared with pre-IVIG before the surgery, and good intensive care and anesthetic support. Um, Recently, we have started using rituximab, and I have seen excellent results for antibody myasthenia for sure, but also in children with acetylcholine receptor antibodies, it is very effective in pediatric form. And therefore, there has been an increasing move to try and use rituximab early so we can protect these young children and young people from long-term side effects of all these medications, particularly steroids, as well as the long-term immunosuppression. Here I share some guidelines for which are international for guidance of guidance for practitioners who do not have experience for myasthenia gravis. And I did organize myself a workshop on juvenile myasthenia gravis back in 2019, where there were more than 10 experts on pediatric myasthenia gravis worldwide. We all got together and drew up some guidance for pediatric neurologists and pediatricians who see only one or two children sometimes. So I already explained the medication pyridostigmine and how it works. And there's not a fixed schedule, but generally we try to say titrate it according to the child's activity. And this is a cholinesterase inhibitor, so it makes this acetylcholine last longer over here, so that they can work better and are less tired. Um, this is the pathway that we came up with in the ENMC workshop that we did, that when we have a child or a young person with myasthenia gravis, antibodies are confirmed. We start with pyridostigmine, and then if there's acetylcholine receptor antibodies, we arrange for a scan. If there is a scan, which shows thymoma, then we have to go for thymectomy immediately or early. If there is no thymoma and the symptoms are only related to eyes, then and we are happy with this response to pyridostigmine, we can just continue that and maintain them. However, in majority of the situations, that's not enough, and there are ongoing symptoms even with the pyridostigmine, and then we add on the alternate day prednisolone. And if there's good response, again, we try to reduce that to the minimum effective dose. But this time duration is often good 6 months, because to build up it takes quite a lot of time. And then once we've reached the peak dose, once we have good efficacy, we need to maintain that immunosuppression for some time before we start reducing to the minimum effective dose. Sometimes I find that colleagues reduce it quite rapidly, and then that leads to relapse. So I try not to do that. Um, if there is no um, response to the steroids and the disease is quite moderate to severe and is antibodies are positive, I will refer for thymectomy, and in preparation I will arrange for plasma exchange or IVIG before. But I think it's important to highlight that thymectomy is not an emergency procedure. We would only undertake this when the child and young person is stable from the respiratory perspective, and we may use steroids, IVIG, plasma exchange, etc., to stabilize the child before we undertake the procedure. If the child is antibody is negative, um, and there's no on is negative, we continue to look for other possibilities for diagnosis, like investigations. I may do a muscle biopsy, or I may undertake a brain scan. If there is no need for thymectomy, and then we might try to use other immunosuppression like azathioprine, plasma exchange, or IVIG. And again, if there's no response to this, we may try to use other medications like rituximab. In all situations, I think the eventual um, goal is to try and have maximum control of symptoms with minimum effective dosing and side effects. So we try to minimize the toxicity but have the maximum benefit. And I think that's the balancing act that we need to do. And that's the goal that we are working to. Obviously, recently there are quite a lot of few clinical trials that are being undertaken in pediatric myasthenia gravis, which I'm involved in. But we wait eagerly the results of these studies to see if these are a choice for children. Um, And talking about a little bit more about the thymectomy, this is the systematic review for juvenile myasthenia gravis, and it was an international, review of international patients globally with quite a large number. And you can see that the post-operatively there was improvement in 70%, and 30% gained complete control of symptoms, which was sustained for a long time. So it's relatively safe, and there are not major complications, and is well tolerated. Um, Even if there's no thymoma, we would recommend this for acetylcholine receptor antibody, generalized myasthenia gravis. This is another study also reporting similar outcomes. This also allows us to reduce the toxicity of the other medications. When we do the thymectomy and the response is seen, we can then start taking down some of the other medications. I think the important thing from your point of view, when would you seek help? I think in the acute situation, this is really important to remember that if you have any trouble with swallowing, any trouble with breathing, or infection, or a sudden change in your muscle strength, I think it's important to immediately present to your local hospital, accidents and emergency department, or you have a fast track access to your local hospital so that you can be immediately treated. This is what we call MG, myasthenia gravis crisis, and these are the indications where you have swallowing, respiratory difficulties, or sudden loss of independent mobility. And in these situations, we would use plasma exchange using this machine where we filter out the antibodies, or we might use IVIG. So in all my children that I look after, I would give them in every consultation we will talk about saying that please, if you have an acute problem, report to your local hospital and ask them to contact us for advice. In day-to-day life, there's some practical advice that we give about pacing. Also, we have a neuromuscular CNS who helps us in the myasthenia clinic as and when she can. She liaises with school if there's problems with participation in PE, or quite a lot of school attendance is missed because of poor disease control. also to support them emotionally, particularly in the troublesome teenage years when these children go through quite a lot of changes anyway with puberty, etc. And on top of that, to have this variable disease, which sometimes peers and other students and teachers might struggle to understand why children can do some things on one day and can't do the same task on another day. So they do need quite a lot of support from this aspect. We also talk about diet and maintaining a healthy weight. Because of the steroids, there is always a risk of gaining a lot of weight. And I think the other trouble of not being able to burn those calories puts them at even higher risk of rapid increasing weight gain. So we work closely with the dietitian to try and provide some advice about healthy eating and at least monitoring the weight so that it's not sharply increasing. I mentioned earlier about, talking about the future directions and, what's coming. So in the last year, there has been um, in the UK a rare disease clinical network set up for juvenile myasthenia gravis. This is a NHS England initiative, and this is it's not funded, but I think what it allows us is for the peers across the country, colleagues to gather in meetings once a quarter to discuss any complicated cases, but also to educate each other. We have invited speakers where we would discuss some interesting topics or novel therapies. And for the moment, John Radcliffe Hospital in Oxford and Great Ormond Street Hospital are both hosting this rare disease clinical network for juvenile myasthenia gravis. Um, in addition to this, I mentioned earlier about new therapies on the horizon. So there are clinical trials ongoing for efgartigimod, which is a FcRn receptor blocker, also for zilucoplan, which is a complement C5 inhibitor, which we are using in clinical trials, and we wait the results of these trials, which will probably be another few years before we have them. In addition to that, eculizumab is available in the US. It's been FDA approved recently in juvenile myasthenia gravis. So these are the different new biologicals which are being tried and recommended. Um, and from where I see it, I think these are, for myasthenia gravis in general, not only for children, these are some, really the best and the worst times because there are so many new therapies that have been approved for adults, and the trials are ongoing in children. But the questions are which patients should receive which therapies? Which one do you try first? Should you try the biologicals right away, or should you try the standard, more traditional approach of giving predostigmine, then steroids, then the secondary line, and reserve these new therapies, which are very expensive for the last and for the most difficult children. Also, we don't know the long-term safety of these drugs in children, but also in the short term, we need to be assured the side effects are not going to be more than the benefits. So I think it's really important to watch the space very closely and keep yourself, for the colleagues and professionals to keep themselves up to date with what's happening in this field. But I think the good times are coming, and it's time for personalized treatment to think about: is it mask? Is it acetylcholine receptor? Should I use, Plex, or should I use thymectomy? Should I use rituximab? Should I use IVIG? So really important considerations. This is my last slide with some concluding remarks. So, juvenile myasthenia gravis is rare, and most pediatric neurologists would see only a handful of children in their practice over a decade, and therefore I think concentrated practice allows us, and certainly has allowed me to understand the disease better, and it's clearly treatable with so many different treatment options available. But I think the first important message is recognition is the key to minimize the morbidity and mortality in this condition. um, I always recommend when I teach students and trainees and resident doctors that please assess for fatigue in any child or young person who comes in with drooping of the eyes or weakness. Um, and myasthenia gravis in children is at the moment much more manageable than it used to be. There's so many options, and more in the last couple of years, I have seen children and young people return to completely normal, asymptomatic life with minimal manifestations, the goal is met and they have very minimal toxicity. So I'm pleased to report that, these things are working, but I'm sure there's a lot more work to do. And I'm sure we and Myaware will continue to work for this in the coming years. Lastly, acknowledging the entire team. So this is the team at Great Ormond Street Hospital, my neuromuscular consultant colleagues and nursing colleagues. Emma and Olivia work with me in the myasthenia clinic. Emma is a CNS and Olivia is one of the physiotherapy colleagues. Also, I work with the team in Oxford at John Radcliffe with Professor Palace and Dr. Ramdas. Um, and this is this was taken recently at the myasthenia patient day. So I'm happy to take any questions, um, and thank you for this opportunity.
Thank you so much, Dr. Munot. There was a lot in a short space of time, and lovely to hear the background and to see the bigger picture as well, I think. So I think that will only be helpful for people watching this. Thanks so much. As Dr. Munot said, if you have any questions, maybe get in touch with Myaware. Just drop us an email to support@myaware.org and we can pass the questions on, and that will be a wonderful opportunity. So thank you so much for your time. Thank you.
Thank you, Sarah.